Good morning again. Thank you, Dr. Galar and Dr. Kim. Base of the ventricles. I studied the cardiac imaging from the morphologic point of view, and I always find that base of the ventricles is very helpful in understanding normal and pathologic anatomy. So this is the base of the ventricle. What you do is that in the heart, you remove the right atrium, aorta, pulmonary trunk, and left atrium above the valve, and you remove that. Below is you have your ventricle, and then you know that your tricuspid, mitral, aortic, and the pulmonary valves pretty much in the same plane. So if you see that from below, there is a finding. So what I would like to do today is that they review the normal anatomy very simply, the point of view interest, and then also that we'll discuss that VSD'S as a simple whole versus malalignment type of VSD'S. I want to skip the TGA and DORV because it is a little bit too long list, and then I'll talk about the straddling, overriding atrioventricular valves and double-inlet ventricles using the anatomy shown in the base of the ventricles. Okay, so these are really the base of the ventricle seen from above. This is the base of the ventricle seen from below. You have the line drawing of this. So one of the very important the issues that the aortic valve is deeply wedged between in the space between the tricuspid and mitral valve. And then here, I want to emphasize that two structures. One is that central fibrous body, which means that central fibrous body is a fibrous skeleton pulling the mitral, tricuspid valve, and aortic valve in place. The reason why it is important is the fact that membranous septum is a septal extension of the central fibrous body. If you remember the position of the central fibrous body, you will be able to remember where the membranous septum should be every time. The reason why that membranous septum is important is the fact that membranous septum is the most common location of the defect altogether, because that is the last to close in the embryogenesis. The second is that that is the close relationship with atrioventricular conduction axis. That's why central fibrous body is important. So this is the location. And then the other is the crux cordis. So crux cordis is the point here. It's not really in the center of the heart. Especially fetal echocardiographer uses the crux cordis pointing the central four-chamber view. Actually, there is the misleading description. Crux cordis is external landmark right here. I will show it better in the other drawing. So having said that, this is the open right ventricle. This is the free wall of the right ventricle. This is the septal part of the left ventricle. You remember that pulmonary valve here, tricuspid valve, and separated by crista supraventricularis or ventricular infundibular fold. Think about this structure. Behind that, you should have aortic valve. So location of the aortic valve is just there. Remembering that between the pulmonary valve and tricuspid valve, above that you should have aortic valve. And then central fibrous body is there, which means that membranous septum is here at the apex of the tricuspid valve on top here. Okay. And then this is a trabecula septomarginalis or septomarginal trabecula, which is a Y-shaped structure, body, anterior limb, and posterior limb. And then this structure is what? Medial papillary muscle of Lancisi, harboring the so-called outlet septum here. So this is the really important landmarks we need to think about. So I want to define the crux cordis for the better discussion of the other things. Crux cordis is the point here where atrioventricular groove posteriorly is intersected by the continuation of intraatrial to intraventricular groove. It is crux cordis. That is why it is named as crux cordis. So when you have your so-called single right ventricle, you still have a crux cordis, the nicely shown crossing point. However, if you have a single so-called left ventricle or double inlet left ventricle, you don't have a posterior descending coming here. So therefore, crux cordis here is defined a little bit differently. Atrioventricular groove posteriorly intersected by intraatrial groove. That is the definition of crux cordis. Okay. So let's start here, talk about here the major issues. So VSDs, you have two different types. One is that VSD is a simple hole. There is a chopped septal defect taken out. Okay. However, there is another type of VSD. For instance, here, door is here in the ventricular septum with the hinges here, and door is open. And then you have your ventricular septal defect created, which means that this part of the septum is displaced, making a hole in the ventricular septum. That is the whole concept of malalignment type of VSD. Okay. There are multiple type of malalignment types. So well known is tetralogy of Fallot. This outward septum is opened into the right ventricle, moving forward leftward superior, and then causing the subpulmonary outflow tract obstruction and the large VSD and an overriding aorta. And the other is that so-called coarctation of VSD, which means that infundibular septum or outward septum is actually pushed backward into the left ventricle, causing subaortic stenosis and then various degree of aortic arch narrowing. Okay? So that is the posterior malalignment. This is called anterior malalignment commonly. And then the other is that tricuspid valve and the valve straddling and overriding, and mitral valve straddling and overriding. You probably remember that tricuspid valve overriding straddling is through the posteriorly located VSD, while mitral valve straddling and the overriding is through the anterior located VSD. That should be revisited. So that is not very accurately described in the literature. Okay. So this is the new developed concept. What it is that if you talk about the septal malalignment, there are multiple things you need to think about. First is that which part of the septum is actually malaligning. The second is that which mechanism is the malalignment is. Most importantly, relative which structure. So that is the commonly that not very well described. That's why that we have some misunderstanding of this, and direction of malalignment and extent of malalignment. My advice is that when you're talking about malalignment of VSD, let's describe 5 features of malalignment in such a way. So mechanism of malalignment, I find that there are 2 mechanisms. One is the flap door mechanism, the other is en bloc displacement. Flap door mechanism is like this. You have your door open, you have a VSD here. So there is this structure making something. En bloc displacement is like this. Okay. Okay, so example is that outward septal malalignment. So reference is the rest of the ventricular septum. Outward septum is malaligning. Outward septum is what? This is subpulmonary outflow tract, this is subaortic outflow tract, and this is the outward septum. Simple definition. It is not necessary between the right and left ventricle. Normal, yes, but in the pathologic heart, it does not have to be right or left ventricle. Subpulmonary, subaortic. So this is a situation simulated as the sinus-solitudinous concurrent AVVA connection. This is a transposition. Aortic valve is a pulmonary valve is here. So let's see what the flap door mechanism is. So this is what the flap door mechanism, and then pulmonary valve, because of flap door, it is squashed and then stenotic. While because of this, aortic valve is moved forward. Here, you think that here, pulmonary valve, aortic valve actually married to outward septum. That's why aortic valve is pulled forward because of flap door opening. So with the flap door, aortic valve is moving forward. That's why in tetralogy of Fallot, you have your aortic valve overriding. But if you look at the tau C being anomaly, and then somehow, not all, just everything en bloc moved forward. What it means is that this displaced outward septum is parallel with the rest of the septum, with the posterior valve, which is usually the pulmonary valve, overriding. So this is one form of tau C being anomaly. Okay. So the other is here. So I intentionally made the 4 cardiac valves in usual situation and transposition. Okay. So tricuspid valve straddling is different. What it is that your hinge is anteriorly, and this rear door is open in such a way, flap door. So which means that ventricular septum divorces crux cordis, and then you have a more posteriorly located looking ventricular septal defect with the tricuspid valve overriding and straddling. Okay? However, mitral valve straddling is completely different way. The same one, this septum is heading this way. Your hinge is in the crux cordis, and then anterior part of the septum is moving. Actually here, this one, malalignment is relative to atrial septum, and then hinge point is anterior, hinge point is posterior. That's why you feel tricuspid valve straddles in the posterior location, mitral valve straddling is anterior location. Be careful. Anterior does not necessarily mean that is the outflow tract septum. It's nothing to do with it. Your inflow septum, inlet septum is abnormal already. So, can you get it? Okay. So this is because of this displacement, there's open pulmonary stenosis, and then you have this one, displacement, aortic valve and pulmonary valve belong to right ventricle. That's how mitral straddling is often associated with double outlet right ventricle, especially tau C being anomaly. Okay. So let's talk about the outlet septal malalignment first. So there's tetralogy Fallot, double outlet right ventricle, double in the outlet left ventricle, coarctation type VSD, or outlet septal malalignment relative to rest of the septum. So this is the old angiogram, very nicely shown that this flap door mechanism. So the door should be here, and then your hinge point is here. So door is open toward the pulmonary outflow tract, as shown here. You have the subaortic, the VSD with aortic overriding, and subpulmonary outflow tract stenosis. So here, this is the cavitogram, and this is the real the 3D reconstruction of tetralogy Fallot, aortic valve, outlet septum, pulmonary outflow tract, and then this is the case. Okay. So here is the thing, the usual description: leftward, anterior, and superior deviation of the outlet septum relative to the rest of the septum. That's how we describe tetralogy Fallot. Let's describe a little bit better. What it is that, let's talk about this. Malalignment part. Which part of the septum is malalining? Outlet septum. Mechanism of the malalignment. Flap door mechanism with a hinge on the left side. Okay. Reference structure is the rest of the ventricular septum. Direction is leftward, anterior, and superior. In this case, extent could be 80% of or 70% of aortic overriding and moderate to severe subpulmonary stenosis. And then you have pretty much good description of what the malalignment is. This is an easy, the practice of the subaortic malalignment type of VSD. Okay, let's talk about this. If you look at the literature, there is a lot of description about posterior malalignment. Almost all angiograms or echocardiography show this. Outlet septum is deviated posteriorly, encroaching subaortic outflow tract. What it is that here, door is here, but however, hinge is along the aortic valve, and that hinge is pushed backward, so that this is pushing back, and then therefore you have subaortic outflow tract. And then you have muscle bundle here. If it is a simple perimembranous VSD as a simple hole, you cannot have the outlet septum below the aortic valve. This is the only mechanism how you can have aortic, the outlet septum below the aortic valve. Okay. So describing this, so the 5 points, malalignment part is outlet septum again. Mechanism is a flap door with a hinge on the top, not on the left or right. Reference structure is the rest of the ventricular septum. Direction is posterior and superior. And extent in this case is causing moderate degree of left ventricular outflow tract obstruction. Okay. So left ventricular outflow tract, looking at this of the base of the ventricular diagram, there are a couple of mechanisms. One is that this malalignment outlet septum. The other is that the so-called anterolateral muscle bundle of Muller, and the other is so-called anteroseptal twist as an additional factor to make the left ventricle outflow tract obstruction. So what it is that malalignment outlet septum is here. Anterolateral muscle bundle is between the aortic valve and the mitral valve here from out, coming into this space. Anteroseptal twist is from the anterior part of the septum toward the space between the aortic and mitral valve. So all of this conspiring to make the left ventricular outflow tract narrow, depending on how you describe, the literature describes it very, very differently. But however, this is a little bit simplified way of understanding. I wish that this is helpful. So let's talk about the double artery right ventricle with the subpulmonary VSD, so-called Tau-Bing anomaly. So this is one of that. So you have a right ventricle, small aorta, large pulmonary trunk arising from the right ventricle, infundibular septum or outlet septum here. So opening that, you can see tricuspid valve, aortic valve, pulmonary valve, bilateral infundibulum. VSD is below the pulmonary valve. Okay, outlet septum is to the right margin of the VSD. And seen from above, this infundibular septum goes to the right margin of the VSD. What happened is that from the usual type of complete transposition, which is the case here, so tricuspid aortic valve, mitral pulmonary valve, so this is the LV, this is the RV. So if it is rotated as shown with the arrow, pulmonary valve will move forward. Okay, with that, because as I said to, outlet septum is married to the aortic valve and pulmonary valve in such a way, outlet septum is deviated rightward and superior here. So causing malalignment VSD below the pulmonary valve. So the other case, here describe it, malalignment part is outlet septum, mechanism is flap door with a hinge on the right. Okay. And then reference is rest of the ventricular septum, direction is rightward and forward. Extent in this case is 80% overriding of pulmonary valve and moderate subaortic stenosis. Okay. This is not every case of Tau-Bing malformation. There are cases of having the Tau-Bing with a more anterior-posterior location of the aorta and pulmonary trunk like this. Here, if we open this, you have the VSD here, aortic valve here. This is the outlet septum. So if you look at this from above, what it is that this is the intraventricular septum, this is tricuspid, mitral, and you have aortic valve and pulmonary valve. You can see the pulmonary valve overriding. Look at the outlet septum. Outlet septum is completely parallel with the rest of the ventricular septum. What it means is that everything, including pulmonary valve and aortic valve, push it forward, en bloc displacement. So mechanism of the malalignment part is outlet septum in the presence of TGA morphology. And the mechanism is en bloc forward displacement. Reference structure is the rest of the ventricular septum. Direction is forward. Extent is that to cause 80% of overriding of pulmonary valve and mild subaortic stenosis. Okay. So comparing this, these are two different types of Tau-Bing. Tau-Bing malformation, outlet morphology is not uniform, as you see in the pathology literature. It's different. Here is the flap door mechanism. This is en bloc displacement mechanism. So these are the difference. Okay. Let's move on to the straddling AV valves and double inlet left ventricle. So this is the D-loop ventricle or right-hand topology. And then you have your right side right ventricle, left side left ventricle. It's normal, right? Tricuspid, mitral, aortic valve, spatially a little bit overriding, and pulmonary valve here. So here, let's say this interventricular septum divorces the crux cordis, which should be here, move to this, and then you have a tricuspid valve overriding and straddling. If that septum moves forward, and then two AV valves come into the left ventricle, so therefore, double inlet left ventricle, and then you have this great arterial relationship. When you have a double inlet left ventricle...
2 minutes to go.
Thank you. To the very frequently, you have the posterior median muscle ridge present in the center here. Okay, so let's move on to here. You have L-loop ventricle, tricuspid valve straddling. You have a similar phenomenon. Okay, so the other is that mitral valve straddling. Here, one thing that you should remember is that tricuspid valve straddling, whole ventricular septum is displaced forward, divorced from the crux cordis, making the tricuspid valve overriding. Mitral valve, crux cordis is maintained, and the anterior part is the moving backward. Okay, so let me move very quickly here. So to show, I have a little bit, I expected that this explanation can take a little bit more time, but okay, so, oh, come on. Yes, yes, so this is the tricuspid valve straddling. So malalignment part is that whole ventricular septum, not the inlet, not the outer only. And mechanism is a flap door with a hinge on the front. Okay, and then the reference structure, this is important. Reference structure is the atrial septum, not the rest of the ventricular septum. And the posterior let the crux cordis in here, and direction is right and forward. Extent is the 30% versus 100%. Overriding tricuspid valve. So mitral valve straddling usually occurs in the morphology of transposition. So malalignment part again is the whole ventricular septum. Mechanism is a flap door with a hinge on the back at the crux cordis. Okay, and then reference structure again is the atrial septum, not the ventricular septum. Direction is leftward and backward, and the extent can be minimal versus the 100% the overriding mitral valve. Okay, I want to stop here. Thank you very much for your attention.